Good morning, everybody. Welcome to Provincial Stroke Rounds. We're going to get started for today. My name is Sue Verrilli. I'm the Regional Education Coordinator with the Northeastern Ontario Stroke Network, and we're based out of Health Sciences North in Sudbury. Today's presentation is titled Non-atherosclerotic carotid bifurcation diseases, phenotypes and their management, and will be presented by Dr. Ravinder-Jeet Singh, Stroke Neurologist and Medical Director for the Northeastern Ontario Stroke Network. Just a few reminders before we get started. The handouts from today's session will be shared in the follow-up email that will be sent out later today. This webcast will be recorded and archived and can be accessed through the link provided in the follow-up email. Please keep your microphone muted during the presentation. And a reminder that the views expressed today are those of the presenter. We will have an interactive component held during the last 10 minutes when we'll have a question and answer period, and we hope to hear from as many of you as possible. Please take a moment to type your questions into the chat throughout the presentation. You can see the evaluation is on the screen right now. Please complete it by scanning the QR code. As well, we'll put the link into the chat before the end of the session. Certificates of attendance were attached in the email invite. Please fill in your name and keep for future reference. Now it's my pleasure to introduce our speaker for today. Dr. Ravinder-Jeet Singh is a stroke neurologist at Health Sciences North here in Sudbury, and he's the medical director at the Northeastern Ontario Stroke Network. As well, he is an associate professor at the Northern Ontario School of Medicine. He completed his medical school and neurology training in India. He did a one-year stroke fellowship in India before moving to Calgary, where he completed his 2-year vascular neurology fellowship at the University of Calgary. He has a strong interest in studying the role of brain eloquence in stroke prognosis. He is also passionate about studying long-term outcomes after stroke, carotid bifurcation diseases, and optimizing stroke systems of care. Welcome, Dr. Singh.
Thank you, Sue, for the kind introduction. And can you hear me okay? Is the
Perfect.
sound quality fine? Okay, perfect. Great. So thank you, everyone, for joining. And I hope that you are having a better weather than I do. It looks like the winter is never going to end. In any case, so I'll be talking today about non-atherosclerotic carotid bifurcation diseases, phenotypes and their management. And one of the reasons why I'm focusing on the non-atherosclerotic carotid diseases because there has been a lot of interest for many decades in the atherosclerotic carotid disease, and I think a lot has been written, published, and there has been a lot of randomized data available to help us with the treatment of the atherosclerotic carotid bifurcation disease. But there has been very little written or understood about the non-atherosclerotic spectrum of the carotid bifurcation disease, which is what the focus would be today. Here are my disclosures. I did not receive any financial or in-kind support for today's presentation. I am a site PI for many of the clinical trials, and I also have funding from the NOAMA here locally. The learning objectives are to first explain what is the spectrum of the non-atherosclerotic carotid bifurcation diseases, what really comes in that the big basket. And the second is I will be touching upon some of the more common non-atherosclerotic carotid bifurcation diseases, which are more relevant to day-to-day clinical practice, although they are relatively common among the entire spectrum, but they're still quite rare or uncommon in the general practice. So I'll be focusing on 4, the non-atherosclerotic spectrum, which is carotid webs. Intraluminal thrombus actually can be associated with atherosclerosis, but can also be could be a manifestation of non-atherosclerotic septal diseases. The third would be stylocarotid syndrome, also called as vascular eagle syndrome, and the fourth one is the Tippich syndrome, also known as carotidynia. The concept of stroke is not new, and this has been known since the 5th century by Hippocrates. And at that time, everything was referred to as apoplexy, whether it was a convulsion or paralysis. In 17th century, there was more understanding about the vascular nature of the stroke, and it was not until more recently in the mid 20th century that C. Miller Fisher um, led to the publication of several pathological studies and clinical correlation, which led to the recognition that the carotid bifurcation or carotid artery in general is important for stroke cause and had a very important therapeutic implication of that understanding was the multiple trials which were conducted about the carotid endarterectomy and subsequently stenting, and now we know that these are standard of care. What kindled my interest in the non-atherosclerotic side was these three cases, which I came across at different time of my training. The first on the left, as you can see, the small shelf, it's a case of carotid web, which I think it was over 8 or 9 years ago. And the second was a case with the intraluminal thrombus, which the interest which I further pursued, and I'll be presenting some of the data. And the third is the vascular eagle syndrome, where you can see this big, long styloid process compressing on the intracarotid artery. So although the interest was kindled by the first case, the subsequent cases continued my interest in the non-atherosclerotic spectrum, and some of which I'll be discussing today. So I'll go over the first case, which I was doing my fellowship when I came across this important case. Although I had come across carotid web, but this was the case which really triggered my interest. This was a 49-year-old female with no cardiovascular risk factors. So her initial presentation was actually about 4 years prior to when I first saw her. And when she initially presented with this sudden onset of headache, dysarthria, and left-sided numbness and weakness. And so she had the initial imaging, although in hindsight, we can see there was a branch occlusion, and there was some changes at the left right carotid bifurcation, but this was called normal at that time because it was so subtle. And so this was the follow-up imaging. She had a small stroke, made excellent clinical recovery and of course she had the usual workup and was on aspirin monotherapy. 4 years later, and that's when I saw her, she presented again with stroke symptoms with sudden onset dysarthria, left-sided sensory loss, and weakness with an IH of 15. And so here you can see the CT. On the left panel, you can see there's a left M1 on the major MCA occlusion. And on the delayed phase, you can see that there's a hang up of the contrast on that side. She was treated with both thrombolysis and thrombectomy, and this was the post-procedure MRI, which shows a small embolic-looking infarct. And so we went back and looked at why this young patient without any risk factors is having a recurrent stroke. They're all looking embolic. There has to be something in the artery itself which is causing this. And we carefully looked at the carotid bifurcation, and then we did see the shelf-like projection. And if you see on the axial imaging, you can see this subtle septum in the right carotid bifurcation. And of course, this was also present during the previous CTA, which was done 4 years earlier. This was during the thrombectomy. When the run was completed, you can see there's a nice shelf-like projection arising from the posterior wall of the carotid bifurcation, and you can see a nice contrast hang up, which shows there's a stasis cranial to that web. Now, stasis is a very important marker because it suggests that this part of the artery is more predisposed to form clots. And it's similar to left atrial appendage, where there could be a stasis and stagnation and clot formation. And after the second stroke, she underwent resection of the web. And here you can see the histopathology, largely it was collagen deposition with some myxomatous degeneration, and there was no inflammatory cells, there was no calcium or atherosclerotic plaque, and you can see there was some breakdown of the internal elastic lamina along its course. It's absent here in this segment. So now coming to the overall spectrum, now this was one case which kindled my interest, but when I started looking at the whole spectrum, as many of you might have come across some of these conditions, it's fairly broad. It's much broader than the spectrum of atherosclerotic carotid bifurcation diseases. And it starts from the liminal pathologies where you have intraliminal thrombus, which could be present on the plaque, or it could be unrelated to the plaque. Like, for example, carotid web can have a thrombus, or it could be carotid thrombus arising from the heart. And there are neural pathologies where it's predominantly the vessel wall. One of the most common one is a trauma to the carotid bifurcation, which it's much more exposed part of the cerebrovascular circulation. And then you have the non-inflammatory spectrum, where I think the most understood or most widely studied is a dissection, and which may or may not be associated with fibromuscular dysplasia. And then less common variant, which is the carotid web. And then, of course, there are vasculitis spectrum, including the giant cell arteritis, which can affect carotid bifurcation, although it's much less common. Typically, it's the extracranial or the branches of the ECA. But there has been more case reports of involvement of the aorta or even the carotid arteries. And vascular tumors can there are certain tumors which involve the carotid bifurcation, and then there are extra neural disorders, which is where the pathology lies outside the vessel wall, and two of which I'll be discussing today is carotidynia or Tippich syndrome, and I'll be going over the expansion of the Tippich syndrome, and stylocarotid syndrome, which is basically a conflict between the styloid process and the internal carotid artery near the bifurcation. The carotid blowout syndrome is seen more in the head and neck cancer patient who had either the radical neck dissection and following that had radiation, where the skin undergo necrosis and the carotid artery is exposed, and there could be a necrosis of the carotid artery wall. There could also be conditions involving ICA or intracarotid artery in the cervical segment, including a bifurcation. In rare instances, the RCBS has been reported to involve the extracranial component of the intracarotid artery. The carotid moyamoya is another. Typically, moyamoya is the supraclinoid ICA, so it's an intracranial disease, but there has been involvement outside the intracranial arteries, and also the carotid spasms, usually in the setting of RCBS. The other conditions are the dilative arteriopathy, which can present with kinking, coiling, and loops, and there are some connective tissue disorders which can be associated with this, including arterial tortuosity syndrome and Ehlers-Danlos or Marfan syndromes. So as you can see, it's a fairly broad spectrum, and I'll be covering four of the more common ones, including the carotid intraliminal thrombus, the carotid web, the carotidynia or stylocarotid syndrome, which are much more common. So starting with the first, which is carotid web, I think it's now more increasingly recognized as an important cause of stroke in patients who are younger without significant risk factors, as I showed the first case, which kindled my interest in this condition. And it was first reported in 1968 by Rainer et al. But subsequently, there were very few case reports up until early 2000 when there was a renewed interest in this condition because of the widespread use of the CT angiogram, and we were seeing more and more carotid webs than we had seen earlier. And there has been numerous terms used in the literature. So if you come across these terms, it's pretty much mean the same thing, including septal fibromuscular dysplasia, atypical fibromuscular dysplasia, carotid bulb, atypical FMD, carotid artery web, carotid pseudo-valvular fold, thrombotic carotid megabulb. There was only one series which used this term, carotid bulb diaphragm, and intimal FMD. So all these terms basically refer to one and the same condition. And so the key phenotype is it's a non-atherosclerotic fibrointimal membrane, which projects into the lumen of one or both carotid bulbs. So that's the key theme. As you can see in this picture on the right, you can see a nice thin membrane which is projecting from the posterior wall of the carotid bifurcation. Usually it is directed cranial, or it could be perpendicular, but it's never directed caudal. As you can see the picture on the right, there's another septum which is directed caudally. It's usually a ruptured plaque rather than the carotid web. The pathology consistently showed dysplastic tissue, and that's why now it's considered an intimal variant of the fibromuscular dysplasia. And here you can see a tissue or the resection specimen, which shows a nice membrane dividing the carotid bifurcation. In terms of the prevalence, as I mentioned initially on the catheter angiogram, it was reported as a very uncommon condition, largely because the angiogram were used for a variety of indications. But as you can see, moving downwards, once you're more selective in terms of which population you're looking at, you will find it's not as uncommon. And if you see patients who are younger with a cryptogenic stroke in the anterior circulation, the prevalence could be as high as almost 20%. Now, there has been several studies over the years which showed that there's a consistent association between the presence of the carotid web and ipsilateral stroke, as well as the subsequent stroke recurrences. And these are some of the studies which suggest odds ratio anywhere between 8 and 24. From pathophysiological standpoint, it makes sense. As you can see in this picture, the carotid web creates a place for spaces or creates a cul-de-sac, and that leads to stasis cranial to the web because of the flow separation and recirculation zone. And that's where the thrombus forms. And when this thrombus dislodges, it causes an embolic type of a stroke. The stenosis is generally mild. If the stenosis is very severe, it can cause a mixed type of embolic hemodynamic, but I would say most of the reported cases didn't show hemodynamically significant stenosis, so the predominant mechanism is embolism. The key demographic features are the patient where we really need to suspect carotid web is the younger patients. It's much more common in women, but it's very well described in men. And although there's some racial predilection, but it has now been reported in all ethnic groups. But in general, if you come across a younger patient with a stroke, with otherwise cryptogenic cause, in addition to looking for PFO, make sure that you look at the carotid bifurcation, that there's no carotid web causing the stroke. The presentation could range anywhere from asymptomatic detection of the web on the CTA done for other indication to a TIA to an embolic stroke presentation. And conventional risk factors are generally absent, or there are very few risk factors because they're usually younger patients who are healthier. And the other important thing which to look for in the imaging is to look at the contralateral side, because almost half of the patients with the web tends to have a contralateral web, although it could be much smaller. If a patient has a stroke because of the web, the recovery parallels the ischemic stroke in general, with most of the patients having a good recovery. As long as there was no large vessel occlusion going without treatment. Of course, now with thrombectomy being available, even patients with a large vessel occlusion tends to have favorable prognosis. Recurrence rate is quite significant, and no matter which study we look at, it has consistently shown that the recurrence rate in patients with carotid web is quite high and could range anywhere between 17 to 71%. Now, of course, there is some degree of selection bias in these studies because a lot of these were retrospective cohort, but more recent prospective cohort also shown a very consistent theme with regard to the recurrence. And if you look at the Mr. Clean registry during a 2-year follow-up, almost 17% of the patients with the carotid web had a recurrent stroke compared to only about 3% without. So there is a significantly increased risk of recurrent stroke. The diagnosis, I think the CT angiogram is probably one of the best modality because it allows you to look both cross-sectionally and multiple planes, orthogonal planes, and you can see the typical appearance is as a small shelf coming from the back part or the posterior wall of the carotid bifurcation and projecting some anteriorly. And sometimes these webs could be very small because of the superimposed thrombus, or if there was a previous thrombus and it gets reorganized, it might not lead to such a nice shelf. It might be more a blunted shelf. So it's important that it's not only the thin linear shelf, but the different morphology could also exist in some of these patients who previously had a thrombus. On the axial slices, it's a 3-lumen sign. So you can see there it looks like as if there are 3 lumens instead of the typical bifurcation where you see 2 lumens. And the 2 important differentials are, one is the plaque and the second is the atherosclerotic diaphragm. So diaphragm is when there's a concentric narrowing and it creates a wedge in all or a septum or a ridge in all directions. So that's the diaphragm. But much more common is the plaque. And the typical plaque has a very broad base, as you can see in this picture, compared to a very narrow base in the carotid bed. And also the direction, and this is one of the letter which we submitted to Annals of Neurology, where we showed that the webs are directed cranially and generally at thin, while the plaques or the ruptured plaque, which has a septum, is directed more inferiorly. So it's a type of ulcer. And also you can see the associated calcification is quite prominent, and also atherosclerotic changes elsewhere, which helps to distinguish that from the plaque. The conventional MR is also quite helpful. It shows very similar features, except you can also, if you do a post-contrast study, you can see the contrast pooling cranial to the carotid bed. The catheter angiogram are particularly helpful if the patients are going for the thrombectomy. It's good to have a carotid run at the end of the procedure to see if there's any carotid bifurcation, septum or carotid web. As you can see, the typical signs are that once you inject, you will see a nice septum coming from the posterior wall or posterior lateral wall of the carotid bifurcation. And if you wait or do a delayed run, you can see there's a nice contrast hang up there, which suggests there's a zone of recirculation and potential stasis, which predisposes these arteries to form thrombus. The carotid Doppler is not very sensitive, although one of the studies showed that is almost 86% of the patients you can pick up, but these are the patients where the diagnosis was clear. So if the operator is unaware or the reader is unaware of the diagnosis, then it's produced only very inconspicuous bulbar growth, so which could be very easy to miss. And so usually it's the CT angiogram or the MRI, which leads to the diagnosis. The treatment has been variable. No randomized controlled trials. For that matter, there's no large prospective study to report. There was one done more recently, but I suspect there has been a lot of inclusion of patients which could be of atherosclerotic etiology. In any case, most of the studies report that the recurrence rate is significant when the patients are on medical therapy, no matter whether they are on antiplatelet or anticoagulation, although the number of patients who are exposed to anticoagulations are much smaller. But patients who undergo carotid revascularization, either the stent or endarterectomy, both the short-term and the intermediate-term data shows there's no recurrence. So it could be one argument for considering an early treatment, although one could debate one way or the other depending upon how the carotid web looks like. And I'm happy to address if this is one of the questions which comes up later in the discussion. Just to contrast the carotid web, which is the intimal type of fibromuscular dysplasia, the conventional fibromuscular dysplasia has much more widespread involvement. And so as you can see here in this picture, you can have the carotid or the cervical ICA involvement with the beaded appearance of the ICA. You can also have the vertebral artery involvement. You can have involvement of the renal artery. So it's a much more a wider phenotype compared to the carotid webs, which are more restricted phenotype. And aside from one case report, most of the studies haven't shown any involvement of the renal arteries or extra carotid involvement in patients who have a carotid web. The difference in the treatment compared to the carotid web, the general fibromuscular dysplasia approach is to avoid triggers for dissection, and the medical therapy if patient had the stroke, and some cases anticoagulation. Although this is based on the literature review, there hasn't been any again randomized data. The endovascular stenting is considered for patients who have a quite significant stenosis due to the FMD. And occasionally there has been need for the resection because of the arteries too loopy and cannot be stented. In those cases, you can perform surgical resection and end-to-end anastomosis. So the second condition is the intraluminal thrombus, also known as free-floating thrombus, and there has been other terms used in the literature, including intraluminal clot and non-occlusive thrombus. Now, this is more of a general expression of different conditions present at the carotid bifurcation, including the carotid web. So patient with carotid web can have intraluminal thrombus attached to it, but much more common is the plaque. As you can see in one study, prospective study where I was involved in, we looked at consecutive patient with the intraluminal thrombus prospectively, and the plaques were the most common cause, almost 71%. Although the non-atherosclerotic etiologies are significant, constituting almost about a third of cases, the undetermined cause, again, could be divided into multiple categories because undetermined could have two different pathologies existing. So you can have a carotid web and patient also has AFib. So in these cases, it's hard to determine what is really the cause for the thrombus. Although if the thrombus is clearly seems to be sticking to the web, we could argue that that could be a clear sign that the web is the cause. Or there could be patient could be hypercoagulable, like has cancer and has AFib. So these are the patients who goes under the undetermined category because they have more than one cause present. The carotid web, although in this series it was, I believe that there was only one case, but in general, if you only study younger patients with the intraluminal thrombus, I suspect the numbers are going to be much higher. The predominant stroke mechanism, of course, is embolic. Although because of the presence of the stenosis, coexisting stenosis, you can also have hemodynamic mechanism, and the diagnosis is based on CTA or MRA. And in patients who are going intervention, of course, they undergo catheter angiogram or DSA. The carotid ultrasound is helpful, but the presence of thrombus is best seen on the cross-sectional imaging with either CTA or the MRA. The treatment of the intraluminal thrombus has been quite debated. In general, there seems to be a trend using the anticoagulation-based strategy, which could be either unfractionated heparin in the past, but more recently, people are using low molecular weight heparin. And we generally combine it with the single antiplatelet, especially if there's the presence of associated plaque. But it could be pure anticoagulation-based strategy. And the initial treatment in the study, which we published, we used almost all the time a combination of the anticoagulation with one antiplatelet, which was either aspirin or the Plavix. The prognosis generally is quite favorable in these patients, although the thrombus is present. Most of these thrombi tends to respond to this combination antithrombotic. Almost three-quarters of the thrombi tends to resolve either partially or completely within the first week. And the recurrent stroke seems to be generally low in these patients, especially in short-term risk is relatively low. And this was another study which my colleague and I, we did in a survey of how the stroke physicians tends to approach this. And my colleague, Dr. Ganesh, is working further to design a trial to address this. And what we basically landed up with the conclusion is it's the equipoise exists because there's no randomized data or even large prospective data, except the one where we published about 73 patients. That was the largest prospective data available in the literature. There has been subsequent systematic reviews combining all the data from the previous studies with a very similar conclusion. And again, looking at the paper I was mentioning, the in-hospital stroke recurrence rate was only about in about 4 patients among 61 where the follow-up was available. And if you look at the resolution of the thrombus, its complete resolution is seen in about 27%, and partial but significant debulking can be seen in about another third of patients, with some resolution in about additional 10%. And about 25% of patients, there is no change in the thrombus in the first week. What is interesting is if you look at the patients where they initially had a large thrombus and therefore the stenosis looked quite severe, if you do a follow-up, actually quite a few patients drop their level of stenosis from over 50% to under 50%. And so it's very important from the treatment consideration, because once they are under 50%, generally these patients are not treated with the carotid revascularization. So a follow-up imaging is generally helpful in these patients. Also, most of the interventionalists are not comfortable doing a stent or even surgeon doing a surgery in the presence of the intralemal thrombus. So treating them with the anticoagulation and then doing a repeat scan in about a week or so allows these thrombus to either recanalize or organize so that they are less likely to break during the procedure and embolize. Okay, so we'll move on to the third condition, which is the stylocarotid or vascular eagle syndrome. And again, I will present one case which I came across. It was about 7 years ago. An 81-year-old female who presented with 6 months history of near passing out, where she would say that if she's sitting and all of a sudden she will feel as if the room is closing in. She had few such episodes, but never had any complete syncope or syncopal episode. And these were unrelated to any neck movements, or at least the patient was unaware of this association. But about 2 months prior to her presentation, she noticed that she had 4 different episodes, 2 of which involved the speech, the other 2 involved the vision. And all consistently occurred while she was turning her head to the left side. On one occasion, she was having a conversation with her friend and turned her head and consistently was looking at her. And all of a sudden, she started losing words and could not speak for a few seconds. As soon as she turned her head back, after a few seconds, she started to speak normally. There was another instance where she was at Walmart and looked to swipe her credit card on the machine, and then suddenly couldn't speak with the person next to her. And there were 2 other episodes where she lost partial vision on the right side, and in hindsight, it was a field vision loss. And when we did the CTA, as you can see here with the red arrow, you can see there is this styloid process, which is indenting on the internal carotid artery. As you can see, there's quite a bit of stenosis. Here you can see the styloid process is fairly long and is impinging on the ICA. And this is another view just to show more severe degree of stenosis. And interestingly, this patient did have the fetal origin of the PCA, or posterior cerebral artery. So we think what happened is because of the low flow in the ICA, she had on occasion the PCA involvement causing the right visual field loss. And this patient was initially planned for a styloid resection, but this was around the time of COVID, and when she was scheduled for the styloid resection, um, which was many months after the initial presentation, the COVID hit, and then subsequently she could not undergo the surgery. But clinically, she did extremely well and only had one more recurrence about 3 years later or 4 years later. And so we did not pursue because this was very infrequent occurrence. And plus, at that point, she was almost 85 years old, so we didn't want to pursue the carotid resection. And she has now been followed for additional 2 years and hasn't had any further recurrences. She's maintained on aspirin monotherapy. So what is Eagle syndrome? It's a constellation of symptoms caused by an abnormally elongated styloid process. So styloid process usually is about 2 to 2.5 centimeter long, so 20 to 25 millimeters. But when it is elongated more than 3 centimeters or 30 millimeters, it could start to compress on the adjacent neurovascular structures, mainly in the carotid sheath, which has the internal carotid artery, has the internal jugular vein, and also the lower cranial nerves, as well as the periarterial sympathetic plexus. And depending upon which structure it impinges on, it can cause different types of manifestations. It could be vascular dominant manifestation, or it could be more of a neural manifestation related to the compression on the sympathetic plexus, which can present with Horner syndrome, or involvement of the lower cranial nerve, including glossopharyngeal, which can cause neurologic pain. And so that is the two major presentations, which is the classical is with the throat pain or the neurologic pain. And the second is the stylocarotid or a vascular presentation, more typically with the carotid artery compression. But more recently, there has also been reports on the jugular venous compression, which could cause episodic pulsatile tinnitus in the ear. The initial description was back in 1927 for the classical variant, and in 1949 for the vascular variant of the Eagle syndrome. As mentioned here, the elongated styloid process is quite common in general. About 4% of the general population has it. So therefore, just the presence of elongated styloid process is not a diagnostic of Eagle syndrome. It's the symptoms associated with the elongated styloid process which leads to the diagnosis of Eagle syndrome. And again, depending upon its predominant vascular phenotype or pain phenotype, it could be classified as a classical versus the vascular variant. So the typical demographic features are middle-aged adults and slight female predominance, although the all age groups has been reported to have vascular Eagle syndrome. The key features are it could be incidental, or it could present with TI or stroke. The patient which I described had recurrent TIAs in the carotid distribution. The patient can have syncope, usually because of the irritation on the sympathetic plexus, and they can also develop Horner syndrome if there is a damage to the sympathetic plexus. And there could be also neck pain or headache. This is very important in patients where the elongated styloid process could lead to dissection in the artery. And there has been now several studies which showed that the elongated styloid process is one of the risk factors for the spontaneous carotid dissection. And of course, as I mentioned, the pulsatile tinnitus could present if the internal jugular vein is compressed. The diagnosis relies heavily on the cross-sectional imaging. The CTA is optimal imaging approach, although MRI could be alternative, but the bone is not that well seen on the MRI compared to the CTA. We could also do dynamic assessment, where you can turn the head to the symptomatic side, or the side which triggers the symptoms, and you can do the Doppler in the neutral position and in the symptomatic position, and you can show how the Doppler velocity increases because of the increased stenosis. You can also do a dynamic CT angiogram, which actually I did not show here, but we did in our patient, where you can do the CTA in the neutral position and then turn the head to the symptomatic side or the side which triggers a symptom, and maintain that position and repeat the CTA, and you can show the increased amount of stenosis. The DSA again is a very useful tool, but of course it requires more of an invasive approach, and can be done in select cases where you're unsure and unable to demonstrate the dynamic compression on the Doppler or the CTA. The management predominantly is medical, which could be merely observation in asymptomatic cases, or you can add antiplatelet if there are ischemic symptoms or there's any dissection or thrombus. In select patients, you can consider a surgical resection of the styloid process, which is usually a partial resection, and it could be either transoral route or transcervical route, and it could partly depend on if the patient is having recurrent symptoms or if there are significant associated pain syndrome, which could be another reason why these patients undergo resection. The last condition I will touch is the carotidemia or Tippich syndrome. And so again, similar to the other condition, it also involved a carotid bifurcation. It was initially described by Fay in 1927. And it was a purely clinical description by tenderness and pain at the level of the carotid bifurcation. And what is interesting is that it was part of the or entity in the first ICHD classification, which is the classification of headache disorders in 1988. But then there was a lot of discussion or debate as to whether this is truly a distinct entity or merely a reflection of different underlying conditions. As we can imagine, patient with carotid dissection could have pain in the neck and can have local tenderness. Patients with stylocarotid syndrome could have a local pain. There could be other conditions which can cause like vasculitis, which can lead to the pain. So therefore, it was recognized that this is probably not a very a unique condition. It's probably a reflection of different underlying condition till 2017, when Leclerc proposed that instead of calling this as a carotidemia based on purely clinical, which is pain in the distribution of the carotid artery, is instead we should use a more of a clinical radiological approach, which is transient perivascular inflammation of the carotid artery syndrome. And so what this study did was basically refined the initial clinical description and added the imaging to support the imaging features so that it now forms a more unique syndrome rather than a general clinical syndrome, which can be mimicked by many other conditions. The prevalence of the Tippich syndrome or carotidemia ranges between under 1% in more of a regular practice to in acute pain clinics. It could be in the range of about 2.8%. The typical demographic features are middle-aged adults, slight female predominance. And the key features which leads to the diagnosis is acute unilateral neck pain localized to the carotid artery regions, which is just below the angle of the mandible. The pain is usually continuous and throbbing. So the throbbing nature suggests this could be avascular. And it's worse with the head movement because when the head moves, it stretches the carotid sheath along with it, and that causes the worsening in the pain. And if you press at the carotid bifurcation just below the angle of the mandible, there's a point tenderness and a very severe tenderness at the very focal point. And about less than 10% of patients can have a preceding viral illness, and about 15% of patients can have other autoimmune conditions, suggesting that this is probably some kind of inflammatory condition. And so this is the revised criteria which has been proposed, and which basically includes the pain as the key theme. And the imaging includes eccentric, usually it's a CTA, or the preferred is actually the MRI in this with the post-contrast study, where you can show an eccentric perivascular infiltration, which is an amorphous soft tissue replacing the fat around the carotid artery bifurcation on imaging. And of course, we have to exclude the other causes, for example, dissection or other conditions which can cause similar neck pain. And typically, patient tends to improve spontaneously within a couple of weeks or might require a short-term use of anti-inflammatory treatment. Some of these patients might have associated soft plaque, which could suggest that this can be associated with the carotid athero as well. Here are a couple of examples. So this is the CTA. As you can see here, there's a soft block here, and there's the perivascular soft tissue. This is the MRI. And in MRI, you can see this is a pre-contrast. You can see there's a thickening of the arterial wall. And on the post-contrast study, you can see a plaque here, and as well as the periarterial enhancement, which is the inflammation. And here also you can see starts with the distal part of the common carotid artery, goes into the proximal ICA. So it kind of spans across the carotid bifurcation. And you can also see an associated carotid plaque. So if it is adventitial inflammation related to the plaque, or whether this is an unrelated, it's a bit unclear because a lot of the patients do have this associated plaque, but there has been a lot of reports where there's no plaque associated on the follow-up imaging once this inflammation clears. And again, their management is largely conservative, no randomized data. It's generally a benign condition and self-resolving condition. Some patient might require for pain control, you can use NSAID, like ibuprofen or naproxen for short course. And in more severe cases, or those not responding to the NSAIDs, you can use a short course of corticosteroids for about a week or two. One of the important, which could also be helpful from the diagnosis standpoint, is a dramatic improvement in the pain. So as soon as they're started on the steroid, within 24 to 48 hours, their pain basically disappears. And the follow-up imaging can be done to reassure that the inflammation has resolved. The recurrence rate ranges between about 20% to almost 30%, depending upon the time course of the study. The early recurrences are about 20%, and the late recurrences can occur in additional 10%. I will not go into the carotid dissection, so I'll probably close here. Initially, I thought I'll add the carotid dissection, but I think I'll stop here. So we'll leave the last 10 minutes for questions and discussion. And here's my conclusion. So non-atherosclerotic carotid disease is an important but heterogeneous group causing stroke and many other neurological symptoms. It can occur asymptomatically or can present, as I mentioned, with the local symptoms, ischemic symptoms, or rarely hemorrhagic manifestation, which is more common with the dissections. And diagnosis is possible by use of non-invasive vascular imaging. And the management is evidence-based only in a few conditions. Trigger prevention is applicable for patients with dissection or with the fibromuscular dysplasia, but and is largely medical. Endovascular surgical options are used in select patients, especially those with the carotid webs. And future trials to risk stratify some of these patients with non-atherosclerotic diseases would help to personalize the management approaches. So we still have a long way to go compared to the older brother of the atherosclerotic carotid bifurcation disease. But I think there's now a lot of interest. And if there is any interest by any of the listeners, please feel free to reach out to me, and we're happy to collaborate. My email is at the very beginning of the presentation, and I'll be sharing the slides as well. Thank you.
Very good. Thank you so much, Dr. Singh. I appreciate all the information that you shared. It's very interesting for me, especially I haven't heard a lot of this. If anyone has a question for Dr. Singh, please feel free to type it in the chat, as well as if you'd like to unmute and ask your question, we would welcome that as well. To get us started, I just wondered if there was anything about geography in terms of noticing this. You know how stroke is more prevalent in the Northeast, for example. I just wondered if there was any geography in
Yeah,
terms of
no, thank you, Sue, for this. I think it's a very important question because, as I mentioned earlier, in the carotid web, there seems to be a clear predilection that individuals with the more of uh, African and Asian descent tend to have more commonly the carotid webs than more the Western in the Western hemisphere. Although this has been now increasingly recognized. I'm not sure about the other condition because that has been reported across, and there doesn't seem to be any clear population which is more exposed or any clear regions or geographies which are having more common these conditions. And I would acknowledge or that the data is still quite limited, and most of the data on some of these conditions are only small case reports. So I think one of the reasons why there's less data is because we are not even aware of many of these conditions, and there are patients who present with us because we don't look at it. We never recognize this. As I showed it in the first patient, it took 4 years for us to realize that there's a carotid web and which is causing a patient's stroke. So a lot of these patients, they go unrecognized in the community. The reassuring part is that many of these conditions are more benign and self-limiting, and compared to some of the other ones, which are more aggressive phenotypes. So, but even patients who have benign condition, it's important to have a clear diagnosis, which allows these patients to get more reassured rather than having an unclear explanation for their presentation.
right. Um, do you know if there's ongoing research in this area or if you're continuing to do some research in this area?
Yeah, so there is now a lot of interest in the carotid web. So I would say there are at least two different groups. One is the French group, which who is quite active in the carotid web, and the second is the U.S. group, which I'm aware of, and we have a third one, who are kind of currently working in terms of developing a platform trial to address these different carotid diseases, including the non-atherosclerotic carotid disease. So yeah, so three different groups which are currently active. Locally, we are setting up a registry, an imaging database to specifically look at these conditions. And hence my shout out if there's any interest, we can certainly collaborate on this project.
Right. So that means in the future we should have a bit more information
Absolutely,
based on that
absolutely.
research. Excellent. People can continue to type in the chat. A few people are thanking you for a great presentation. I want to remind people to do the evaluation. So we've put the QR code and the link also in the chat. It just takes 2 minutes and it helps us in planning our future rounds. Is there any other questions for Dr. Singh this morning?
Yeah, it looks like either I was too clear or too nebulous.
Well,
Yeah, but yeah, no, I would say even if I raise the awareness for some of these conditions, and if you can take back to your clinical practice, and if the patient comes with unexplained stroke, looking for carotid web, if patient comes with the neck pain in the carotid bifurcation region, especially with the local tenderness, look for carotidynia. If the patient comes with any positional symptoms of TIA, or episodes of syncope related with the head movement in certain position, look for stylocarotid syndrome. And then, of course, the intraliminal thrombus is largely based on the imaging, so patients coming with the stroke. So even if there's an improved recognition, and I think that itself would be a big achievement for me to kind of raise this awareness of these conditions, which has been largely unrecognized and with very little research in this field.
mhm. Great. Thank you very much. Um, there's more thank yous in the chat if you'd like to read them. I just want to remind people our next provincial stroke rounds will be hosted by Southwestern Ontario Stroke Network. They'll be held on June 4th, 2025. The topic is building awareness, helping kids understand stroke and aphasia, and will be presented by Lisa Sampson and Alessandra Di Peretti. Please note we're continuing to trial our new time for stroke rounds So these rounds will begin again at 8:30 a.m. Eastern Standard Time. So if there's no more questions, I thank everybody for joining us, and we'll be sending up a follow-up email sometime today. Thanks very much, Dr. Singh.
Thank you, everyone, for joining. Have a great day. Thank you.